Okay, I think we can begin with the chair of the Headache Special Interest Group of the British Pain Society. I'm sure you all know the British Pain Society is the oldest and largest multidisciplinary professional body in the field of pain within UK. And it does aim to promote education, training, research, and the development in all fields of pain. So today, our seminar will be based on facial pain conditions. And before I would like, yes, I would also like to remind you that we have the annual meeting. We just had the one in 2024, which was a very fantastic meeting. And we would like to invite you to the next one, the 58th annual scientific meeting, which will be in June in 2025 in the International Convention Center of Wales. And also some housekeeping rules before we start the seminar. You can ask questions. There is a Q&A button meeting, and we would prefer if you put your questions there. There is also the chat box, but it's better if you put your questions in the Q&A box. This webinar is recorded and it will be available in the British Pain Society YouTube channel, and you will receive links for this if you have registered to participate in this webinar. And also, please fill in the evaluation form to claim your certificate of attendance, and you will receive links for this as well. Okay, so to begin today with our seminar, we will be discussing facial pain, diagnosis of facial pain conditions, as well as treatments mostly when the traditional oral pharmacological treatments fail. So I'm joined tonight with Dr. Giorgio Lambro, who is a consultant neurologist at the Headache Center, and with Dr. Stefano Palmisani, who is a pain consultant at the Pain Management Center. Both the services are part of the bigger Pain Management and Neuromodulation Center at Guy's St. Thomas's Hospital. And together they have put a very nice multidisciplinary facial pain clinic, which sees usually the difficult to treat facial pain patients. So we will start with the diagnosis of facial pain with an emphasis on trigeminal neuralgia by Dr. Giorgio Lambro, and then we will proceed with Dr. Palmisani on the minimally invasive treatments for these facial pain conditions. Dr. Lambro, good evening.
Hello, good evening.
Start by sharing slides. Yes, welcome. Yes, we can hear you.
Can you see my slide?
Not yet.
Oh, okay. Give me 1 second. Can you see them now?
Yes, they are just up. Yes, we can.
Brilliant,
yes,
brilliant, brilliant.
Just to remind both speakers, we have 20 minutes for each talk, and then we'll have enough time to discuss anything we left behind.
Absolutely, absolutely. You're right. So thank you very much. Thank you very much, Anna. Thank you very much, everyone, for attending tonight. The topic is really interesting, and as Anna was saying, at Guy's St. Thomas's, we put a lot of emphasis in trying to create a multidisciplinary setup for the diagnosis and treatment of complex facial pain. We see patients from all over the country. You can see on the left-hand side our catchment area. This was one of the when we looked at the patient that were referred to our center. That was just post-COVID though, and the service is growing. And I really suggest, if there is any trainees in the audience, to reach out to us, because we're very happy to have them in our clinic, so they can have a flavor of what we see at the facial pain clinic. Now, you can see the picture here. Stefano is not in the picture. I'm really sorry. I realized that too late. But the core of the clinic is made by us two, and then the skull-based neurosurgeons, the oral surgeons, our facial pain nurses, and when needed, psychologists. So what I'm gonna, let me see if I can advance this. The other very important thing is that we work in collaboration with the Trigeminal Neuralgia UK Association, which is the largest charity for TN in the UK, and we now expanded the remit of this charity into all the forms of facial pain. So if you have patients that you want to have information, or they want to raise awareness about the condition, they want to talk to other fellow sufferers, point them towards the TNA UK, because they are doing a great job in raising awareness, supporting families of patients with these conditions. So what is new in the field of facial pain? First important thing to say is that because facial pain is, especially chronic neurological facial pain, is a multidisciplinary, multi-specialty condition, quite often the main problem is that no one knows who is the lead clinician in managing these patients. Sometimes it's a maxillofacial. So today I saw a TNP, a trigeminal neuralgia patient, and he never saw a neurologist, never saw a pain specialist. His care was led by a maxillofacial surgeon. And of course, the diagnosis was wrong. So the point is that facial pain is, the diagnosis is shared in different classifications. And but thankfully lately, the pain and the headache neurology classifications that work together in creating a combined orofacial pain classification that you can see here, published 4 years ago, and that nicely classifies all the form of dental and non-dental orofacial pain condition. Now, I'm not going to talk about all of them, of course, but I'm going to put some emphasis on the on trigeminal neuralgia for obvious reasons. But then I'm going to try and talk about the differential diagnosis of TN, bringing some examples in terms of cases that we see that we've seen in clinic. Now, as you know, TN is divided into purely paroxysmal if the pain comes and goes in electric shock stabbing episodes, which are normally centered over one or more division of the trigeminal nerve on one side, short-lasting, and often, very often, precipitated by innocuous stimulation of the face, skin, and gums on the side of the pain. And normally there shouldn't be any other neurological symptoms, although some patients have some tingling or paresthesia or dysesthesia post-attack, and that's allowed. But what is not allowed is to have persistent numbness or motor weakness or persistent tingling in the area, technically. And then you've got the second form, what was called atypical TN, which is essentially a form of trigeminal neuralgia with persistent facial pain, which normally is described as a dull ache, at times is described as burning pain, and then on top of that, people experience the stabbing exacerbations. Now, a few cornerstone clinical features of TN that we must know are the first one is that the problem being a a peripheral branch or a cranial neuralgia of a cranial nerve is that the pain has to be unilateral and quite often has to be limited to one or two branches. When all the three branches of the trigeminal nerve are involved, then you have to start arguing whether the problem is more central rather than being centered over one of the branches. Now, there is a possibility of having bilateral trigeminal neuralgia, but then that's normally quite rare, and you need to rule out other causes. The other very rare situation is having V1 first division trigeminal neuralgia. So when that happens, you have to rule out other more headache condition like the trigeminal autonomic cephalalgias. The other important thing is that very, very rarely trigeminal neuralgia is exclusively made by spontaneous attacks. Okay, so if someone comes to you saying that the attacks are triggered by lights, noises, and cold drinks and nothing else, you have to doubt that this is trigeminal neuralgia. Quite often there are multiple triggers: brushing teeth, touching face, wind, talking, eating, and that reflects the sort of peripheral drive of the problem. The other important thing is that in a good proportion of patients, there are trigger areas, and quite often they are centered around the the corner of the mouth and side of the nose. The other important factor in terms of TN is the presence of a refractory period, meaning that if one of your patients triggered the pain, after a while they can continue the action that triggers the pain without precipitating an attack. The pain dulls down, and they're able to accomplish the action that the pain was preventing them to do, namely eating or brushing their teeth, for example. And this is in contrast with what we see in trigeminal autonomic cephalalgia like SUNCT SUNA, where there is no refractory period. So when is possible to gather this information, it can be quite important in clinical practice. Now, in terms of imaging, we know that a CT scan of the brain is not enough. An MRI scan of the brain is not enough to diagnose TN. We need an MRI with high resolution of the trigeminal sequences because that is now a criterion for the diagnosis of trigeminal neuralgia. And we know that this occurs very often, but we also know that there are situations where you have a neurovascular conflict, but patients don't have TN. So it's still valid, the fact that we don't base the diagnosis on the MRI, because there are people with migraine and cluster headache that can have trigeminal neurovascular conflict. This is the new classification of trigeminal neuralgia. You can see how you can discriminate the three different groups based on the results of the MRI: idiopathic, classical, secondary, and then you look at the presence of persistent background pain or not when you want to characterize the problem further. Now, trigeminal neuralgia is, largely speaking, overdiagnosed. Okay, so as soon as there is some level of paroxysmal neuropathic pain in the face and the X-rays of the teeth are normal, is quite often the case that TN is diagnosed. Okay, but what happens quite often is there are lots of other conditions that can mimic TN that are quite often overlooked. Now I'm gonna talk about one case, staying in the field of trigeminal neuralgia, see what you think. So this is a 65-year-old man with a 3-year history of facial pain, left V3, intra-extraoral. He has constant background pain, and then the superimposed severe stabbing electric shock painful episode lasting up to 10 minutes, occurring 5 to 10 times a day, spontaneous and triggers. It is unclear whether he has a refractory period. He had a mild response to carbamazepine, and the MRI scan showed no neurovascular conflict. Okay, so there are some unusual features for what we describe as classical TN, and I can, you can see them there. And so the diagnosis here, I hope you got it, is idiopathic, no neurovascular conflict, no brain tumor, MS, or aneurysms, trigeminal neuralgia with concomitant continuous facial pain. This is the typical presentation. Normally, the MRI scan is more often normal than not. Patients tend not to respond as well as in classical trigeminal neuralgia to carbamazepine and the other medication. And they also tend not to respond as well to microvascular decompression and trigeminal gastric ganglion lesioning procedures. So it's a little bit of a more difficult to treat condition. And I think because of that, it's important that we recognize it so we can tailor the treatment around the patient's needs. Now, and in this case, the patient responded well to a combination of pregabalin and lamotrigine. Pregabalin for the more constant burning pain, lamotrigine for the more paroxysmal component of the pain. But you can see how we needed polytherapy for this particular case. Now, this is another potential case that may mimic trigeminal neuralgia. So I show you the diagnosis, but essentially is a man that 75 years old, diagnosis atypical TN, like what we saw before, had 2 microvascular decompression. One gave him 12 months relief. The other one didn't work, and he had an hemorrhagic stroke. He flew to the US to have the treatment. He's a UK resident. And so when we saw him in clinic, he told me that the pain was just around and behind the eye, no radiation anywhere, attacks lasting up to 10 minutes. And then when I asked him about the cranial autonomic features on the side of the pain, he mentioned that he was having profuse lacrimation and runny nose on the side of the pain. And that had been the case for forever. Okay, so it wasn't something that happened after the microvascular decompression. So the diagnosis was more in keeping with SUNCT and SUNA. And the treatment of choice of this condition is lamotrigine. So the patient was placed on this treatment, and he almost became pain-free at 200 milligrams. With great disappointment because he had to undergo 2 brain surgeries and experience an hemorrhagic stroke instead of just taking a tablet. And so that's why diagnosing these conditions it's quite important in clinical practice. And now this condition mimics trigeminal neuralgia, overlaps with it. The pain is more focused in V1. Attacks are longer lasting, okay? It's quite often chronic, so people have got attacks all the time, and whereas TN is more episodic, coming in bouts, at least at the beginning. And then there is this very interesting overlapping feature, which is the presence of cutaneous triggers, like in trigeminal neuralgia. The main difference is that in SUNCT and SUNA, there are cranial autonomic features. In TN, there shouldn't be. Now, there is a bit of a problem with terminology, but SUNCT and SUNA are essentially the same condition. SUNA is a bit of a broader group of neuralgiform type of pain, and SUNCT should be a subgroup of them where redness of the eye and lacrimation are the most prominent cranial autonomic symptoms. Now, TN and SUNCT and SUNA are overlapping condition. They are put in differential diagnosis quite often. And as I said before, these are the main differences that you have to look out when you see a patient that you don't feel have trigeminal neuralgia and you want to explore something else. Don't be misled by the location of the pain. I saw a patient this morning with left V3 paroxysmal attacks lasting 5 to 10 minutes with watering of the eye and redness of the eye. So pain only in V3, ipsilateral autonomic symptoms. So that can happen. So always ask the same set of questions to make sure that you can get all the information that you need to make a proper diagnosis. Now, the treatment of this condition overlaps, but it differs. So you can see lamotrigine being the treatment of choice for SUNCT, carbamazepine for trigeminal neuralgia. In terms of transitional treatment, gum blocks work in about 40% of people with SUNCT. IV lidocaine works for both, and facial Botox has got anecdotal evidence in SUNCT and SUNA, and quite emerging evidence in trigeminal neuralgia. In terms of surgical intervention, it's very interesting to note that even people with SUNCT and SUNA can have a neurovascular conflict, and microvascular decompression work in both conditions, although is supposedly to be more effective in trigeminal neuralgia. Neuromodulation of the occipital nerve, occipital nerve stimulation, has got open label evidence in SUNCT and SUNA, and there is only one case report in trigeminal neuralgia. I'm heading to the end. So this is a case a bit more complex. So it's a 33-year-old female with a 7-year history of facial pain. So she had a lower wisdom tooth extraction, and then the pain started probably after that, although she wasn't sure, and then it got worse after the COVID vaccine. The pain is left-sided, V2, V3, intra-extraoral, also along the tongue, daily, continuous, very severe, throbbing and sharp, no autonomic features, no migraine symptoms, no associated neuropathic features. Tiredness and stress can make it worse, and there is no family history of headache. Neurologically, she was fine, and tried a few anti-neuropathic, tried sumatriptan, tried indomethacin to rule out myoclonic continua, and she was slightly better on a high dose of lamotrigine. Now, so she had the usual dental assessment, CT sinuses with ENT, MRI brain and pituitary, which shows a bilateral neurovascular conflict, even more confusing. So now what is this? So is it a post-traumatic trigeminal neuropathic pain, potentially because of the onset after a dental procedure, but no neuropathic pain? Is this a orofacial pain, orofacial form of trigeminal autonomic cephalalgia? Potentially, because the pain is unilateral and throbbing, but there are no convincing autonomic symptoms, and the indomethacin trial was negative. Can this be orofacial migraine? You know that in 1 to 2% of cases, migraine can present just with pain in V2, V3. And potentially the pain is there, it's throbbing, patient is young, tired, and some of the triggers are in keeping, but there are no associated migraine symptoms. The pain is strictly unilateral, which is unusual, and there isn't any genetic predisposition for migraine besides the fact that triptans didn't work. Could this be persistent idiopathic facial pain? So the pain started after a minor procedure. It was vaguely in the face, but the patient wasn't able to really give us a dermatomal distribution of the pain. There were no neuropathic signs, and investigations were normal. So we thought eventually this was a form of persistent idiopathic facial pain. Now, this is a form of facial pain that is often a diagnosis of exclusion. We need to be really careful when we diagnose this, and sometimes it can have some neuropathic features. Sometimes it can have some migraine features. So there are some people that suggest that there is a neuropathic or neurovascular variant of this condition, but the reality is there is a lot of research that needs to be done. Now, is this an intractable pain? Not in my experience, so it's difficult to treat, but I have a good group of patients that respond quite well. Normally, you need more than one treatment. Normally, you need medication, and sometimes you need injectable treatments. Although there are some cases that we saw one a year ago, I think, with Dr. Palmisani, that we treated with everything that we could possibly offer, and nothing worked. So there are some also very refractory cases, and so that, you know, it's a multidisciplinary effort when it comes to these very complex cases. And the difficulty is that we don't have any neurophysiological marker, any neurophysiological test that can tell us if someone has got TN with persistent facial pain, post-traumatic trigeminal neuropathic pain, or persistent idiopathic facial pain. We have to rely entirely on the clinical features. And the very last thing I wanted to show you is the opposite. So this is a young male that presented with a very focal V2 pain intraoral. And when the pain was continuous, and then a few days a week, he would radiate to the head, and it would give him a migrainous headache. The pain was very debilitating. Patient stopped working, went to see lots of doctors, had a lot of investigation. He was diagnosed with trigeminal neuralgia, atypical trigeminal neuralgia. He got to the point where he had a neurosurgical assessment, and the surgeon was happy to offer surgery, although he wasn't convinced about the diagnosis. Now, then we saw the patient, and we were not convinced that although he had an X-ray and dental assessment, then dental causes were excluded properly. So we arranged a combing dental CT, which actually showed on the side of the pain an apical periodontitis and pulpitis, which I'm not an expert on this, but he then saw an oral surgeon which did some dental procedure. Ultimately, I think they removed the tooth. But what happened when we saw the patient in follow-up? The patient was completely pain-free, and was only experiencing a few migraine very sporadically. And when I spoke to him some months later, he was back to work. So this is the opposite. So the point is, when we are not convinced that the phenotype fits anything, please reinvestigate, ask for second opinions. Don't be shy when it comes to that challenge people that say, oh, dentally was fine, ENT assessment was fine. You're allowed to challenge it. So I hope I showed you that the diagnosis of facial pain and chronic facial pain remains challenging. Trigeminal neuralgia is probably overdiagnosed, and we really need to phenotype the patient properly to exclude other variants of trigeminal neuralgia. There are some overlapping conditions, including trigeminal neuropathic pain, idiopathic persistent facial pain, for which unfortunately we don't have clear diagnostic techniques that can dissect out the diagnosis. And then, as I said before, let's phenotype, and if you're not sure, reinvestigate. Don't assume that whatever your colleagues say is necessarily right unless you are absolutely convinced and that's the case. And I think I can finish here. I hope I'm on time.
Almost on time.
Almost on time. Brilliant.
Thank you, Giorgio. I'm trying to put my camera on, but I cannot put it on for some reason. But thank you, that was lovely. You were on time. And can I just remind everyone to put their questions in the Q&A if they have any questions for Giorgio. And we can proceed with Dr. Stefano Palmisani, who is, as I said earlier, a pain consultant at the Pain Management Center at Guy's St. Thomas's. And he's going to mostly talk about minimal invasive treatments, injectable treatments, and neuromodulation. And I guess, Stefano, these will be treatments to consider when the oral pharmacological treatments fail, right?
That's correct. So we take the difficult patient, the one that the neurologist cannot help. So they take the easy one. And then we try to help the ones that the medications are not able to help. Now, let me get, first of all, let me see where here. This thing is in the middle.
Yes, if you can start on a presentation mode.
Yes, but the button was on top of it, so that's why I couldn't. Can you see something? Can you see the slides, right?
Yes, now you're on presentation mode.
Good.
Perfect, thank you.
Okay. So this lecture should take like 3 hours because it's a really extensive lecture. What I'm trying to do, I'm trying to give you an overview of what can be the pain relief intervention that we use in facial pain. And I assume that most of you guys have some degrees of familiarity with what pain interventions are, so I don't have to explain too many details about techniques and stuff. But in general, we can perform nerve blocks, we can perform RF treatment, and we can perform electrical stimulation, and we tend to apply these to some specific targets on the peripheral nerves, on the joints in the spine, in the autonomic ganglions in the face, and in the spinal cord. Now, the first thing that the pain guy can do, especially in a setting of an MDT, facial pain MDT, is to help with some degrees of diagnosis. So, for example, here you can see that if you inject the C1, C2 facet joint with hypertonic saline, this is the pattern where the patient report pain. And you see that there is some significant percentage of patients that report pain in the face, despite the problem is in the facet joint. So one of the things we can offer patients is some X-ray guided diagnostic injection, especially if there is any radiologically evidence of facet joint arthropathy, to understand whether some of their symptoms, especially if they are atypical and they don't fit with most of the neurological categories that Giorgio has just shown to you, whether these can fit a more facet joints mediated problem. That is not just for the facet joints. You can see here, this is a SPECT CT scan in a subject that has significant uptake of on one of the cervical intervertebral disc. And this is another type of pain that can be referred in the face, and that can be diagnosed and treated with some different type of epidural steroid injection. This is one that we do with a catheter, which is safer, but there are multiple ways to do it. Giorgio mentioned that some patients benefit with occipital nerve blocks that usually are done as landmark blocks in the occipital area. But there are some specific cases where the occipital nerve doesn't travel in between the two muscles that you see here, but it gets trapped mostly in the belly of one of the two muscles that can be identified with an ultrasound, that can be injected and hydrodissected, and that tend to help significantly patients with both either occipital neuralgia or autonomic cephalalgia. They are responding to blocks. Also, this block is more proximal compared to the one that has been done landmark on the skull base, and so tends to be a bit longer lasting. Another quite interesting and very easy and underutilized block that can be done under ultrasound guidance is the V2 block. That is easily done with an ultrasound, where we can place a needle in the just under one of the pterygoid muscle, where there is the V2 branch of the trigeminal nerve. If you inject enough volume, it's a very small space. The injectate can travel all the way up to the gastric ganglion almost, and definitely can provide some degrees of local anesthesia in the V1 and V2 branches. Now, you will ask why we should do that. Now, trigeminal neuralgia is a condition that can be significantly severe. Patients are not able to eat, they're not able to function, and even if there are some medication that can help, the titration phase of the medication, it can take quite a few weeks. Also, some patients, like pregnant people, cannot take most of those medications. So these blocks are a good attempt to try to stop the bouts of trigeminal neuralgia attacks. And as you can see from this graph, these were like a case series of 15 patients that were waiting for a microvascular decompression for trigeminal neuralgia. They were having blocks on ultrasound guidance only for pain relief. And you see that after a series of something between 2 and 5 blocks, the majority of the patients develop significant relief from the symptoms, so much that they did not need to go for an MVD. Now, our experience is not exactly the same. We've been doing this for almost 10 years, but it's definitely a very easy, very safe tool to help people with trigeminal neuralgia bouts where they are very debilitated and they either cannot tolerate medication, their medication are not indicated, or they are titrating the medications. Now, the other quite well-known treatment for trigeminal neuralgia that we as a pain specialist can offer is a RF, thermocoagulation of the gastric ganglion. This is a percutaneous technique which requires some degrees of experience, as the anatomical landmark and the radiological landmarks are not as easy to identify. And the idea is to try to coagulate part of the gastric ganglion and reduce the amount of ectopic signals coming from it in patients with trigeminal neuralgia. Now, the issue with this treatment is that it's very effective, but it doesn't have, it's very effective in the right patient, but it doesn't last as long as a microvascular decompression. And even in patients where the microvascular decompression is not indicated, because basically there is no MRI evidence of a conflict, the relief from this procedure is significant in the first 1 or 2 years, but it tends to decrease quite quickly. And that it doesn't matter which temperature you're using in terms of burning the gastric ganglion, which kind of technique do you use in terms of having patients asleep or patients awake while you're testing whether you're getting the right branches. And on top of this, it does have some degrees of potential risk and side effects. So 40% of the patient develop some degrees of facial numbness, and 4% of them, they develop some form of painful dysesthesia or even anesthesia dolorosa, which is really, really difficult to treat. However, it is still a good treatment, and is also an evidence-based treatment for classic and idiopathic TN without, if there is no MRI evidence of a neurovascular conflict. Now, this is a meta-analysis that simply shows that the MVD is simply more effective in terms of pain relief. As you can see, this is a requirement for additional surgery and procedures that favors the MVD in terms of having less recurrence of pain requiring more surgery or procedures. And the same in terms of facial numbness, the MVD is a safer procedure because clearly, if properly performed, doesn't cause any damage to the nerve itself. However, and also in terms of there are other conditions where the recurrence of the TN following RF is more likely. So patient already had a first RF, they can go for a second one, and they will have at least 3 times risk of failing that one. Previous MVD patients, they are not doing well. Patients that they don't have paroxysmal pain, they have 17 times risk over TN recurrence, even if the RF works. And patients are already starting with facial hypoesthesia. What the RF is mostly used for are those patients where the risk of the MVD is too high. So if you look at the incidence of adverse events following either RF and MVD, that definitely favors the RF. So clearly there is less risk of stroke, less risk of brain damage, less risk of bleeding, less risk of infection. They're all complications that can happen with RF, but at an incidence that is much lower compared to MVD. So sick, all elderly patients, those are more of a target with RF. Also, because their life expectancy is shorter, and therefore the chance that the RF will work throughout their whole life is higher. What I've noticed is that a lot of practitioners do not offer conventional radiofrequency. They don't offer a thermocoagulation of the gastric ganglion, but they do offer a technique that is called pulse radiofrequency, which means, I mean, I'm sure that a lot of pain guys don't know what I'm talking, but it's a non-destructive application of radiofrequency. Now, there is quite striking evidence if you compare the pain score between patient with idiopathic TN randomized to conventional radiofrequency with 70 degrees or pulse radiofrequency limited at 42 degrees and 45 volts, you see that simply the conventional radiofrequency works and the pulse radiofrequency doesn't. And when you cross over the group that you receive pulse radiofrequency and they now receive the conventional radiofrequency, you see that in that case, even the group that didn't respond initially, it does respond. So there is absolutely no indication for PRF. I think it's just exposing patients to significant risk. Now, there are different now protocols of PRF, and some authors are suggesting being more effective. But for the time being, in my practice, I do not offer that in patients with TN. Another interesting target for radiofrequency is the sphenopalatine ganglion. You see in the very complex anatomy of the face, this is an autonomic ganglion where both parasympathetic and sympathetic fibers convey together with sensory fibers from the trigeminal system. So it is a good target for all the facial pain condition where there is a predominant presence of autonomic symptoms. Technically, it's quite easy to do. It needs a bit of, again, a bit of experience and X-ray, but you can easily place the needle in the pterygopalatine fossa and with the patient either asleep or awake, and then use this pulse radiofrequency, which doesn't damage the sphenopalatine ganglion, but it does modulate its activity. It was originally published in 2005, and they were using, they were enrolling patients with generic chronic face and headache pain. This to show you that if you do not work in an MDT environment, then you end up with a mixture of patients that you don't really know what they are, like migraine or sphenopalatine ganglion neuralgia, which is something that is not really within the classification right now. But to give credit to this author, they were the first one to report that 30–50% of those patients were actually doing quite well. We did a small case series with Giorgio a few years ago in both patients with cluster headaches and patients with SUNCT and SUNA. Both of those two conditions have significant autonomic features, and you can see that there is a significant reduction in their responders in terms of frequency of the pain attacks, like 50–60%. Issue is that it lasts 5 to 6 months, so it's not a real long-term treatment. It's also quite interesting to notice that the responders are those ones that have many attacks per week with significant pain scores per attack. So perhaps the patient that we tend to consider are those ones not responding to the medication with a very high number of attacks with a high intensity pain score of attacks. There are really no reported complication besides some facial hematoma because of the maxillary artery puncture. And in some patients, this can be repeated with similar efficacy. And we have some chronic patients that come once a year for their repeated procedure. Now, neuromodulation. So this is another huge chapter. We could talk for 2 hours about this, right? So the idea of neuromodulation is the modulation of the pain pathways with application of electrical stimuli, either on the peripheral nerves, on the dorsal root ganglions, on the dorsal columns, or directly to the brain. Now, I will not talk about the brain stimulation. That is not my field. But paradoxically, in facial pain and headache is one of the very few fields where deep brain or stimulation or motor cortex stimulation is something that has a role, even though it's a very, very small niche role. What I would talk about is almost everything else. So we can apply electrical stimulation to different structure on the head with the idea of trying to modulate different functions. So on the left, you can see a very old technique where a single lead was placed on the base of the skull in order to stimulate the peripheral branches of the occipital nerve. And this is a form of occipital nerve stimulation. The bottom right quadrant shows a different, more modern approach that is able to stimulate at the same time different occipital nerves. You can get the greater and the lesser occipital nerve at the same time on both sides. On the left-hand side, the bottom panel, you can see that for quite a few times, there was a device able to stimulate the sphenopalatine ganglion. That was not a bad idea in terms of technology. Unfortunately, the company didn't end up quite well. They did bankrupt, but I think that the IP on that will be reevaluated because this is a good target for stimulation. And then the top panel, you can see what is a conventional spinal cord stimulation lead, which is a lead inserted into the spine in the epidural space, lying on top of the dorsal column. And the reason why it's used in patients with headache and facial pain is because the trigeminal nerve does have a part of its nuclei that descend in the upper cervical spinal cord. And there is an overlap between the C2, C3 nerve root when they enter the dorsal root, the dorsal horn with this trigeminal nuclei. So the idea was either stimulating the occipital nerve, which is C2, C3, or directly the C2, C3 dorsal horn should be able to give you access and neuromodulating access to the trigeminal, what we call trigeminal cervical complex. So this was tried in migraine, and this is not a headache seminar, and it was a bit of a failure for many reasons that were mostly related to the design of the study. But what is quite interesting to show is that is also tried in cluster headache, which is, again, is a headache condition, but it does mimic more facial pain condition. And you can see here 5 years follow-up of a cohort of patients where occipital nerve stimulation was able to reduce the frequency of the attacks by 50%, the intensity of the attack by 30%, with a 50% responder rate. What is quite interesting, and still I cannot get my head around it, and we discuss this with the neurologists all the time, that there are some patients that were not responding for the first part of the trial that became responders later on, which is quite interesting, as implies that this kind of therapy might have a very long-lasting, slow modulatory effect on this trigeminal cervical complex that can start causing pain relief 6 and 12 months down the line. But this is quite a strong, robust study that shows how ONS can reduce pain and pain attacks in patients with autonomic symptoms for a very long period of time. So there is no other real strong evidence for neuromodulation, despite there are hundreds of different papers published by neurosurgeons, pain physicians with different techniques, all aiming at and targeting either the peripheral nerves or the cervical spinal cord. So this is an example of a paddle lead where neurosurgeons are able to create a small fenestration in one of the lamina of the vertebrae, insert a paddle lead, and that is able to stimulate a trigeminal cervical complex much better than using a percutaneous lead. The downside is you need to have a C1 laminectomy, which is clearly more invasive and more risky. And you can see that he had a quite decent cohort of patients with different type of neuropathic pain in the face, starting with trigeminal deafferentation pain and trigeminal neuropathic pain, postherpetic neuralgia. And all those patients, they do, well, not all of it, but the ones that responded to the stimulation, they did quite well. There are other studies reported by different authors where the insertion of those leads were also performed through the cervical spine and percutaneously. And you can see that, again, the technology seems to be quite effective. There is a significant reduction in pain scores. The problem with all this and with all the cases I will show you later on is that, unfortunately, these devices are not meant to be where we are placing it. Both the batteries and the electrodes. So that leads to a very high revision rate and a quite high late failure in terms of response. In patients with mostly trigeminal neuropathic pain, which is a bit different from trigeminal neuralgia, there is the possibility to implant a custom-made lead directly into the foramen ovalis. We tend to use neuronavigation for that, as is quite a big 14-gauge needle. So you want to make sure that you don't puncture any other structures. The issue with that is that, like most of the neuromodulation technique for facial pain seems to be quite effective at the beginning, but you can see that some patients fail this therapy in the long run. Now, what I want to point out here is because especially for people that don't see a lot of facial pain patients, they don't understand the impact of the facial pain. So of the patient that failed long-term in this trial, 2 committed suicide and 1 requested and obtained euthanasia. So the pain in this subject is so important and so impactful that it's extremely difficult not to treat them. So, and that's the reason why, despite there is not strong evidence for any of those techniques that I'm presenting, there is always the option of exploring them. We did a small case series of different type of stimulator, inserting percutaneous lead in the cervical spinal cord, trying to stimulate the trigeminal cervical complex, and we have quite good results for patients with SUNCT and SUNA. This was an initial, I think 3-4 patients group, but then we have a large database that we are still analyzing, and this is the current way of implanting this patient in our center. Now, just to give you an idea of a real case, rather than just presenting you slides of other patients. So she is a young patient that was sent to us with a diagnosis of well, I don't even remember which diagnosis, but clearly wasn't right. But she was at the end diagnosed with a V2, V3 post-surgical trigeminal neuropathy. She had dental surgery and she developed jaw osteomyelitis. She had allodynia on the face. She couldn't open the mouth so much that for the procedure, she had to go for a awake intubation. And you can see that that was the only thing you could do in terms of opening the mouth. And when we were asking her to touch her face, she wasn't really keen in doing that. What we did was inserting a single lead in the epidural space, targeting the trigeminal cervical complex on the affected side, and starting the device straight after the surgery. She was able to open the mouth more, but more often, more important, she was able to touch the skin without any degrees of allodynia. This girl, I think, wasn't able to eat for at least 4 years, and she was using food by a straw. And since then, she got married, she got a job. Yes, she developed some degrees of migraine. These patients are never pain-free, but she's definitely much better and much improved. And now I think is more than 5 years down the line. A couple of colleagues of mine in the US, they swear by that the way forward for those patients is peripheral stimulation, which means inserting the same leads that I've shown to you directly on the branches of the nerves where the patient feels the pain. This is a quite challenging technique because the jaw is very mobile. The face is not easy to access in terms of placing those wires, placing the extension, and then tunneling those extension all the way to the battery that needs to power those wires. But the results of peripheral nerve stimulation in the hands of skilled surgeons that know their technique is quite impressive. It seems that the patient have less degrees of late failure, and we cannot still explain why peripheral stimulation seems to be more effective than central stimulation. I can just speculate, but we don't really have any evidence. But that is another option especially for patients with unilateral pain. You understand that bilateral pain requires a number of wires in the face that becomes technically not feasible with the current hardware, even though new hardware is coming, which will allow that to. I think with this, I've been on time, and the idea of this lecture is to just give you a very brief overview of the techniques that the pain physician can offer and the targets that we can target, with the idea of helping with the diagnosis or with a possibility of creating lesioning of structure that are hyperactive. And I think that neuromodulation, as I said, is the most promising field, especially because the technical advancements are such that will allow us to place smaller electrodes on peripheral branch of multiple cranial nerves. With this, I think I've spoken enough. Thank you very much for your attention.
Thank you, Stefano. I have to apologize to everyone. My connection is very weak, so I had to join from my phone. Can I just remind everyone, if they have any questions, put them in the Q&A box, so we can actually go through them. Hello, Giorgio and Stefano, thank you very much. Thank you for being online. You are on. I have to admit I had problems with my connection, so I joined from my phone. I hope everyone can hear me. Stefano, thank you for being on time. Thank you for the nice presentation as well.
Recording in progress.
Can I just remind everyone, if they have any questions, to put them in the Q&A box, and we can go through them. Just to ask myself, often the diagnosis is not easy because the patients will come after they tried some medications, or they may be already on medications. So how can you better get the diagnosis correct if the patient comes and the presentation is a bit confusing? I think, Giorgio, you already showed in your first case that the refractory period wasn't very clear, right? So maybe that patient had already some dental procedures done, or they were already on certain medications. So how do you go about having a clear-cut diagnosis, if it can ever be done, actually?
Yeah, so it's a very good question. The answer is not simple in the sense that sometimes we assume that patients that are on medications may have a different phenotype, but also patients that undergo destructive procedures of the trigeminal pathway may then become pain-free for a little while, and the pain comes back, and it changes. So we see quite often cases that have been published as well, where a patient with trigeminal neuralgia undergo, for example, gamma knife or glycerol injection or cryotherapy, and they are pain-free for a year and a half or two. And then when the pain comes, it relapses in a different territory. So, or sometimes what happens, even more interestingly, it changes the characteristics. So we see people that start having trigeminal neuralgia, then they undergo a destructive procedure or microvascular decompression, and then when the pain comes back, it comes back as a SUNCT presentation, for example. So the pain is more around the eye waters. So we see these changes, and I guess if the driver is more central and you try to suppress the peripheral output, then the brain is going to find other branches to express the pain symptoms. So that's probably what happens. And the other important thing is that sometimes people have more than one diagnosis. So there are patients with cluster headache and trigeminal neuralgia. There are patients with trigeminal neuralgia and SUNCT. There are patients with hemicrania continua and trigeminal neuralgia. There are patients with trigeminal neuropathic pain, post-dental, with migraine genetics that then go on and develop neuropathic pain in the face that then triggers migraine on the same side. So that's why it's really important to stress the phenotype. And sometimes, we have to ask the patient to come off some of the medication if we want to get a better flavor of what the diagnosis is.
Mm-hmm. Okay, thank you, Giorgio. And Stefano, can I please ask you, you were right that often we see patients who have tried pulse radiofrequency. What I find striking is that it works for the sphenopalatine ganglion, but not for the trigeminal ganglion. What's your view about this?
Because there are two different types of pathophysiology. So the trigeminal neuralgia, most of the time, is caused by ectopic firing of the trigeminal nerve. We can discuss why that is happening. There are genetic reason, channelopathies reason, the compression with a vessel. But the whole point is that there is an ectopic activity there. So when you use a radiofrequency thermocoagulation, you decrease the amount of fibers that are able to fire. As simple as that. And that is the reason why it works. Because when you reduce the ectopic firing under a specific threshold, the brain most of the times doesn't record that as pain anymore. The sphenopalatine ganglion neuromodulation with a pulse radiofrequency is used in a condition where the sphenopalatine ganglion, we are not entirely sure what is the role there. Definitely the autonomic symptoms go through it, whether they are generated in that specific ganglion or simply passing through. So it's a nice way to access and modulate the activity, but the pathology of those patients is way more complicated and it's not a simple ectopic firing. That's the reason why the conventional radiofrequency has been used on the sphenopalatine ganglion with not great effect and a lot of complication with like localized neuropathic pain and so on.
Okay, thank you, Stefano. And one more question. Do we really need ultrasound for greater occipital nerve blocks? I mean, in migraine, obviously, we do them the whole time without any ultrasound.
No, you don't. The reason why you use the ultrasound is for two reasons. Either the patient has, for example, an occipital nerve condition that is clinically very evident, like an occipital neuralgia, but it does not respond to the block. In some cases, there is an entrapment of the occipital nerve that is more proximal to his emergence from the spine that you cannot capture unless you go with an ultrasound at the level of the neck and not at the level of the scalp. Or if you want to provide a longer term relief, trying to increase the dose of what you are injecting, there is not space here. There is just the occipital nerve, the skin, and the scalp. While here, the nerve runs in between two muscles. You can hydrodissect and create the space where you can inject more than 10, 15 ml, so you can increase the dose of steroids, increase the dose of local anesthetic. But it's not a first-line treatment. It's not a first-line approach for any occipital nerve injection.
And talking about first line, I mean, Giorgio touched a bit on it, about the emergence of Botox in facial pain. I mean, in our center, we use a lot of Botox. Well, a lot of Botox. We do a lot of Botox procedures, Botox injections in facial pain patients. The indications may be different sometimes, but I would say the majority are trigeminal neuralgia patients. What's your view? Should it be much earlier? Should Botox be used earlier on in the pathway of the patient? When should it be used? Obviously, we don't have any randomized controlled trials, but as you said, we don't have any randomized controlled trials for most of the techniques we discussed today. So maybe I would like to have your opinion, and Giorgio can also add on this.
No, I think Giorgio is much more experienced than me. I see patients that fail the Botox.
Good point.
So,
Giorgio, do you want to comment?
So look, there are about 7 open label studies and 2 randomized controlled trials which have been published in China, and I think they're in Chinese. So the only available English literature on this is a meta-analysis done by Chinese authors. So there is a little bit of a problem there. But what appears from these studies is that Botox is highly effective in trigeminal neuralgia. So we're talking about 60 to 100% of responders if you pull all the studies together. Now the studies have been criticized. Sorry?
What dose? At what
yes.
dose?
So exactly. So the studies have been criticized. One, because it is unclear what protocol people have been using. 2, because some people use intraoral injection and extraoral. Some people only use extraoral. 3, because of the placebo effect in the randomized control trial, and the other thing, which is a little bit anyway, but the other thing is the weakening effect of Botox. So essentially, what the studies reported, which I think is also our experience, is that if it's done properly, it's not very frequent to see muscle weakness if it's done in certain territories. Now, as you know, there is a trial coming up, an RCT from a European group, where they're gonna try and create a paradigm which is based on what has been published so far, and they're going to try to do an RCT versus placebo in X amount of patients. Now, whether that's going to work or not is difficult to say, but it seems to be a safe paradigm that is highly reproducible. And Botox, in terms of working in TN, makes sense. So in our experience, I don't know if we've done 30, 40 patients, but it's striking how it works well, and when you repeat it every 3 to 4 months, the efficacy is sustained, and sometimes it helps you when medications cause side effects. People go through an exacerbation. They can't have surgery. They're not fit for surgery. You can use Botox for trigeminal neuropathic pain. You can use Botox for classical and atypical trigeminal neuralgia. So it gives you a lot of flexibility in clinical practice. And people with TN in general, they hate their medications, right? So if you have an alternative that is efficacious and quite easy to administer, I think it would be a good option. When to use it, I would say when the first line treatment doesn't work or causes side effects, or when people have an exacerbation, then you can add Botox on top.
That's perfect. And can I just ask, I don't remember if it was you or Stefano, you mentioned that, there may be an absence of neuropathic symptoms, but often these symptoms can be confusing, right? So what is a clear-cut neuropathic symptom for you that you would consider in your diagnosis?
Is it for me or for Stefano?
I guess for both. I mean, you both diagnosed.
Well, I mean, I would say very briefly that so normally what happens if you have the typical patient that develop post-traumatic trigeminal neuropathic pain, post-dental, and I remember seeing some of them in the oral department at King's. So they initially they have the dental procedure, then they start having numbness and tingling in the territory of the nerve that was lesioned, and pain. And then what happens over time in the majority of cases, the numbness go away, the tingling often remains, the paresthesia remains, and the pain then becomes one of the major features if the neuropathy is a painful neuropathy. And the pain has got burning, stabbing characteristics. There are often cutaneous triggers. There is often this sensation the patient describes as hands crawling under the skin, what we call dysesthesia, and then quite often there is the I would say tactile or mechanical allodynia on top, and you can have a variety or a mixture of all these symptoms, but that's what I would consider more neuropathic. When someone comes and says, "I've got burning pain," and that's it. I don't think is enough to convince me that this is a neuropathic condition, at least peripheral.
I mean,
and obviously, sorry, Stefano, do you want to add something?
So I think that there is a easy distinction between neuralgiform and neuropathic type of pain. And generically speaking, neuralgiform conditions are not caused by a major nerve lesion. And they tend not to be associated with minus signs in terms of sensory and or motor function. It depends on the nerve. While neuropathic pain condition, they can be associated, as Giorgio said, with what we called minus signs in terms of function of the nerve. And then the characteristic of the pain becomes more continuous. It doesn't have paroxysm. And if you couple that with the presence or absence of an injury, a direct injury to the nerve, that makes the diagnosis of neuropathic pain easier than most people think. The issue, as you mentioned before, that when you see the patient, they are on 3 different medications, including antineuropaths and antiepileptics, which morph the phenotype completely. And so patient with paroxysmal pain, they might have some degrees of response from the antiepileptics, and so they report just the background pain, even though there is another one there. So it's really complicated, and it's much easier from when they go to the GP and they have their clear-cut pain phenotype, but we don't see that at all.
So which leads me to my next question. Do we need a multidisciplinary team to diagnose properly this patient?
I can briefly tell you that I think there is you cannot have an MDT for every single facial pain patient. There are some conditions that are quite easy to diagnose. So classic TN should be able to be diagnosed by general practitioner. There is no need to go and see Dr. Lambro, for example. But when the patients do not respond to medications, or when the diagnosis is not clear-cut, then definitely an MDT is important before trying destructive procedure and adding 2-3 medication one on top of each other. That's the way I see it.
Okay, thank you. Giorgio, do you want to add anything?
No, I agree, but the problem is with the new classification of trigeminal neuralgia is is difficult to, although GP should be able to diagnose it, patients have to have an MRI of the trigeminal nerve. And I think then it becomes a bit awkward in primary care because I don't think GPs will know how to differentiate. So if you look at the classification, if you really wanted to make a third level diagnosis of TN, so idiopathic classical secondary, TN, purely paroxysmal or with concomitant persistent facial pain, technically it's being a neurological condition should be at least a general neurologist. Now in the UK we don't have many of those, so it can delay the diagnosis, it can cause some practical problems, but yeah, it should be, and especially if you think that this is a very rare condition, right? So yeah, having said that, as Stefano mentioned, is true. Some patients they are assessed by the dentist. The assessment is normal. The GP normally does an MRI to rule out multiple sclerosis or posterior fossa tumors, and then they put patient on carbamazepine, low dose. A good proportion of patients does really well, and then they kind of left on this treatment for a long time. But for example, I I saw a patient now 4 or 5 years ago that came to me just by chance. It was referred by the GP, but she didn't want to come because the pain was very well controlled on carbamazepine, quite at 50 years old, and she said, "Oh, I don't know why I'm here." And I said to her, "Have you ever had a scan?" And she said, "No, but my pain is so well controlled on carbamazepine. The only thing that I've got is a little bit of balance issues." So she wasn't steady. So I examined her, and she had some retropulsion. So she was essentially, swinging backwards. And so I did an MRI, and she had a posterior fossa meningioma. So now that would have probably become more symptomatic with time, or maybe not. Maybe it would have stayed like that. I don't remember what happened, because then she went to the skull base. But that to tell you that sometimes even the easy cases that are they respond to therapies and first-line therapies. She was on 300 of carbamazepine and the pain was 95% controlled. Then they can have a secondary cause for the TN, and so that's where who should look after this patient. Then it becomes a little bit, and I would say migraine is super frequent, should be able to be managed in primary care. Maybe TN, thinking that is the prevalence is 0.1%. Maybe every patient should see a general neurologist at least once, and then manage in primary care.
Well, I would like to thank you both. What is important to emphasize is that this type of conditions are extremely disabling, very painful, excruciating pain in the majority of the patients. I think a lot of them need psychological support, but not because the condition is in their head, because I posted this seminar in social media and I got lots of messages from patients asking whether they can invite their GP or their consultant who looked after them because nobody believed in their symptoms before. So I think these conditions are real. We have to increase awareness amongst the public, amongst the healthcare professionals. And with that, I would like to thank everyone who attended tonight. As Stefano said, we probably need 3-4 hours to cover this topic. It's a huge topic. We discussed quite a few conditions. There are lots of treatments out there that can work for some of the patients. I think we can manage these patients efficiently. So thank you, Stefano. Thank you, Giorgio. And thank you, everyone, for joining.
Thank you, guys.
Thank you very much. Thank you.
Have a good evening.
Good night. Good night, everyone.